Perfect. Hello and welcome, everyone. I'm going to give just a minute or two to get everyone settled, to give time for some others to log on, and we'll aim to get started maybe at 5 past today. I do want to note for those of you who have your video turned on, we will be audio and video recording the session today. So you are welcome to turn your video off if that makes you more comfortable, or to leave it on, whichever works for you. All right, everyone. I think we should probably get started in the interest of time here. Welcome to everyone, and thank you so much for joining today for the inaugural Research and Dialogue Speaker Series. We are very excited to get this series up and off the ground, and we're thrilled that you're able to join us here today. My name is Amanda Everall. I'm the Knowledge Translation Coordinator for the research group here at the BC Centre on Substance Use. I'd like to acknowledge that today we are joining you with gratitude from the unceded traditional and ancestral territories of the Coast Salish peoples. This includes the traditional territories of the Musqueam, the Squamish, the Tsleil-Waututh, and the Coquitlam nations. The reach of the work that we do here at the BC Centre on Substance Use touches the territories of all 198 First Nations here in BC. I'd also like to take the time to recognize that the ongoing criminalization and institutionalization against people who use substances disproportionately harms Indigenous peoples. I'm going to be starting by just giving a very brief overview of the format for today's talk, after which I'll be passing the mic over to Dr. Thomas Kerr, who will be providing an introduction to today's speakers. As some of you might have noticed, and as I mentioned earlier, we are audio recording and video recording this speaker series. We'll be posting the recording up on the BCCSU website. So as such, we're more than happy for you to turn your video off if that makes you more comfortable. You'll also notice that we've muted all of the attendees for this webinar, just so that everyone can hear the speaker. So we'll be starting today with a presentation, which will be followed by a response from our respondent, placing the research within his lived experience. Following the presentation, we'll have a 15-minute question and answer period. During the question and answer period, you can ask your questions in 2 different ways. You can either use the meeting chat, or you're welcome to use the raised hand function within the reactions tab on the bottom of your screen, and I'll unmute you at that time. And with that, I'd like to pass it over to Dr. Kerr to get our talk started today.
Good afternoon, everyone. It's a real pleasure to participate in the first BCCSU speakers event, and to introduce 2 old friends and colleagues who are going to be speaking today. First, I'd like to introduce Dr. Kanna Hayashi, who is a St. Paul's Hospital Chair in Substance Use and an Associate Professor in the Faculty of Health Sciences at Simon Fraser University, and she is also a research scientist at the BC Centre on Substance Use. Her work spans social and clinical epidemiology, community-based research, public health and human rights, and health services for drug-using populations. Kanna currently leads the Vancouver injection drug user study as a principal investigator, but she also brings extensive international experience, including her work leading the Mitsanpan Community Research Project, a serial cross-sectional mixed methods community-based research project in Thailand, which investigated drug use, healthcare access, and the impact of law enforcement and policing and other harms among people who use drugs in Bangkok. Our second speaker is someone I've known and worked with for over 20 years. And I have to say, I was really surprised. I went looking online for Dean Wilson's recent bio, and I learned a lot of things about him. I thought I knew him well, but I found out online that he's also a motocross motorcycle racer, a professional golfer, and a minor league hockey player. So lots to learn about Dean. But I think most of you will know him as a longtime advocate and activist on behalf of people who use drugs. He was the president of VIDUS during a very critical time in the history of the organization and activism in Vancouver. And many of you will also know him as one of two individuals, along with Shelley Tomic, who were respondents that brought forward the case to save Insight, Vancouver's supervised injecting site, all the way to the Supreme Court of Canada. And for his work, he has been awarded the Queen's Jubilee Medal. He is also a long-term peer representative for the Portland Hotel Society and is the peer engagement lead at the British Columbia Centre on Substance Use. And he is certainly well known across Canada and internationally as a tireless advocate for people who use drugs. So thanks to Kanna and Dean for participating today. And I look forward to the talk and the conversation we'll all have afterwards. And I'll turn things over to Kanna.
Thank you very much. Let me share my screen. Can you see my slides? Okay, great. Okay, thank you very much for the introduction and also inviting me to do this talk today. I'm very pleased to do that. Amanda has done a really nice, beautiful land acknowledgement, but then I also like to acknowledge again the land on which the VIDUS work has taken place. It's the unceded traditional homelands of the Coast Salish peoples, including Musqueam, Squamish, and Tsleil-Waututh Nation. But today, I'm going to provide a brief overview and history of VIDUS, and then highlight some of the key research findings from VIDUS, and end with some more recent work in progress and future research plans for VIDUS. So first of all, the VIDUS is initiated in 1996, and it's one of the longest standing cohort studies of people who use drugs around the world, enrolling more than 2,500 people who inject drugs over the past 27 years. And it's being funded by the US National Institute on Drug Abuse, or NIDA, and then forms a multidisciplinary research platform. This study has been extremely productive, with almost 500 peer-reviewed publications made to date, and many of which have been led by our research trainees, including undergrad and graduate students, postdoc fellows, and clinicians and frontline workers. And it's been a really key tool for surveillance and evaluation of interventions and policies in the field of substance use, which I'm going to be showing some of the key findings. But I also like to mention that we also put an emphasis on knowledge translation activities to really inform, translate our research findings to inform policy and program innovations, including informing Supreme Court of Canada decisions for keeping Insight open. Yeah, VIDUS was born initially to investigate and address an explosive HIV outbreak among people who inject drugs in the Downtown East Side in the late 1990s. And because of that, public health emergency was declared in 1987. However, over the time, aims of the VIDUS has expanded to include looking at issues beyond HIV and broadly more drug-related harm and the social structure inequities around this population. So this diagram shows a little bit quick history of the VIDUS. And in 1996, when it was started, Dr. Mark Injector, who is a professor at the UBC School of Population and Public Health, was the initial PI or principal investigator. But I'd like to acknowledge that important to note that Dr. Stephanie Strategy, who is now a professor at the University of California in San Diego, played a really major role in conceiving and designing the original VIDUS and in managing the study operations at that time. But she was ineligible to be a PI because she was a postdoc fellow at that time. But she has continued to provide mentorship to successive PIs, even to date. So for this reason, we call her godmother of VIDUS. And then later on, Dr. Mark Tyndall has come on board as a co-PI. And in 2004, Dr. Evan Wood, who is a professor of medicine at the UBC and who founded the BC Center on Substance Use of BCCSU, took over the PI role of VIDUS. And then he actually separated out the original VIDUS, which included both HIV negative and positive people who inject drugs, into two separate but harmonized cohorts. So the VIDUS now follows on the HIV negative people who inject drugs. And then access cohort follows people who are living with HIV and using drugs. And then whenever VIDUS participants convert to HIV, then they will be transferred to access so that those two cohorts will be the sister cohorts. Around the same time in 2005, he also created a new cohort of non-injecting street use called at-risk use study or ARISE. And all those three cohorts are harmonized in that we use the same questionnaire to be administered at the same frequency every 6 months. So that allows us to pool the data to do the analysis of encompassing various populations of people who use drugs in Vancouver. And then in 2009, Dr. Thomas Kerr, who just did the introduction of me and Dean, and who is a professor at the UBC Department of Medicine and head of head of the Division of Social Medicine, took over the PI role of the VIDUS. And then in 2015, he actually combined VIDUS and ARISE into one big grant called VIDUS, or Vancouver Drug Users Study, and then took over the PI role of the ARISE as well. And then this VIDUS study aimed at looking at the complete trajectory of injection drug use in this population. And then later, very recently in 2020, I was very fortunate to take over the PI role of VIDUS from Thomas, but then Thomas has continued to be a co-PI and providing mentorship to myself. And then also Dr. Cora DeBeck, who is an associate professor at the UBC SFU School of Public Policy, and who also assumed the PI role of ARISE from Thomas. So a little bit about the epidemiological methods of VIDUS. So it's an open prospective cohort study. We enroll HIV negative adults who inject drugs and live in the greater Vancouver region. This eligibility criteria have not changed since 1996. And then we recruit people on an ongoing basis. So that's the meaning of the open cohort study via word of mouth and street outreach in the database side. And then we have a frontline storefront office in this neighborhood. Once people enrolled in VIDUS, they are followed up every 6 months with an interviewer-administered questionnaire, blood work, including HIV and hepatitis C testing, and a urine drug screening. I'd like to give kudos to our excellent frontline research team here, led by Steve Kane and Christy Zondalt. Their faces, pictures are shown here. And Steve has been working for VIDUS since the beginning. So he's been working for 27 years. So he knows everything about VIDUS. And Christy also has a long working experience with VIDUS over 15 years. We really owe all the success of the VIDUS research to their day-to-day high-risk work being done by our frontline team, recruiting and then following up participants. For example, their work has resulted in really extremely high follow-up rates of VIDUS participants. So that once enrolled, VIDUS participants usually stay in VIDUS as many as 7 years. So that's a really long time, and that allows us to do a really rigorous longitudinal research. Another key important feature of VIDUS is that we revise the questionnaire every 6 months. And then which is actually quite a bit of undertaking because it involves doing research ethics amendments, reprogramming data entry system, and then retraining interviewers about the new questions. But we do this to reflect important changes in the policies and programming happening in the study setting, and also emerging health concerns among people who use drugs. And then VIDUS is on its own a really rigorous research platform, but its strength lies in its ability to be able to collaborate with many researchers from different disciplinary backgrounds, including ethnographic and qualitative research, health economics, and the basic science. And the VIDUS investigators has had a really strong tradition of working with many stakeholders in substance use research field, including people who use drugs, the service providers, and the policymakers. And then in particular, we have had a really strong, long-standing, successful research partnership with the Vancouver Area Network of Drug Users, or VANU. So this is a little quick snapshot of who the VIDUS participants are over the past 5 years. So as you can see, the median age is 46 years old, and about 60% will identify as men, white, and living in around Valley side, and 21% being homeless, and about 2/3 accessing substance use treatment, mostly opioid agonist therapy, engaging quite a bit of high intensity substance use patterns, and then about 1 in 5 experiencing non-fatal overdose in the last 6 months. So why is VIDUS an effective tool for surveillance and evaluation? Like I said, VIDUS is recruiting people from the community, not from a clinic. So that allows us to avoid selection bias that way, because we are not recruiting people who are already connected in the healthcare system. So we are pulling people who are not connected in any healthcare system. Also, the open feature of our cohort, so being regularly refreshing the cohort, allows us to reduce the cohort effect. So whenever a new policy or program is introduced or implemented, then within VIDUS, we usually have some portion of people who are exposed or affected by this new program, as well as others who are not. So that this allows us to do a between subjects analysis or within subjects analysis, like a before and after analysis, or a combination of the two. So then, so that we can identify gaps in service engagement and then conduct rigorous evaluation of the policy change. So I'm going to show you some of the key research findings from VIDUS to date. So our earlier work focused on around the needle exchange programs because of the HIV epidemics going on around that time. And then many people actually questioned about HIV outbreak happening despite having a large needle exchange program operating in Vancouver at that time. So that one of the seminal work led by Dr. Strategy in 1997 actually showed that within the VIDUS, people who are accessing needle exchange programs were more likely to continue sharing needles and to be HIV positive. So that the key message of this article was that calling for more comprehensive support programs beyond needle exchange programs for this particularly a marginalized population. But some people just misinterpreted these findings as an evidence that needle exchange program is not an effective or potentially harmful. So in response to those concerns, VIDUS investigators conducted a series of analysis to really get to the bottom of this issue around the needle exchange program. So this work done by Dr. Wood showed that people who are engaging in the syringe sharing were more likely to report a difficulty getting clean needles. And then when we ask people about the reasons for why they have a difficulty accessing green needles, the top reason was that the limited opening hours of the needle exchange program. So really showing that it's not the needle exchange program as a whole that was not ineffective, but it's more about the participatory barrier to this program that was not really producing a really positive impact in this population. And then, of course, we have a really great community activism going on in the setting. So that VIDUS, in response to this issue, has initiated this peer-run outreach-based needle exchange program called Ali Patrol, and around in 2000. And so once they started, we quickly added the question about the access to VIDUS Ali Patrol in the VIDUS questionnaire so that we can track the uptake of this service among VIDUS participants. And then we were able to show over the first 3 years, access to this particular program has increased significantly, despite having a large scale police crackdowns happening in this setting in 2003. So, and we also were able to show that people who are accessing this particular VIDUS Ali Patrol program was more likely to be homeless, and then also engage in a high intensity heroin and cocaine injection, so that the higher risk of HIV infection. But at the same time, those people who are accessing this program less likely to reuse their needle, so that really showing that this VIDUS was able to show that this program is filling the gap in the conventional needle exchange program, addressing the participatory barriers and then being effective. And then between 2000 and 2002, a lot of changes have been made in the needle exchange program by Vancouver Coastal Health, including decentralizing the needle exchange program, and then moving the focus from exchange to a focus on distribution. So this seminal work led by Dr. Kerr showed that because of this policy change, the rates of syringe borrowing have significantly reduced. And then also HIV incidence has also significantly reduced after this policy change. Again, this is the one of the key examples how VIDUS has been a really effective tool for surveillance and evaluation of new policies and programs. Speaking of HIV, I also like to note this another seminal work done by Dr. Ut, showing introduced the brand new concept of community viral load. So in this work, it showed that the more people living with HIV in access cohort access HIV treatment and reduce their HIV viral load, then the HIV incidence also declines. So this work really catalyzed the HIV treatment as prevention strategy, not only in BC, but also globally. So the VIDUS has been focusing on not only the health policy and the program changes, but also in the changes in the broader social policy and the structural changes. So one of the examples is the examination of the impact of the police crackdown that I have just talked about. That was happening in the downtown east side in 2003. So this work, again, led by Dr. Wood, looked at this impact of this police crackdown in 2003, comparing like 3 months before and after. So that they found that there was no change in the street price of drugs or rates of daily drug use or rates of methadone treatment enrollment. But instead, what they found that this police crackdown led to displace a lot of people who inject drugs outside of the downtown east side core, and increasing the unsafe syringe disposal outside of the downtown east side core, really showing the unintended negative consequences of this law enforcement effort. Of course, VIDUS, one of the key landmark contribution made by VIDUS is to contribute to the scientific evaluation of the insight. VIDUS formed a basis of this evaluation. And as many of you may know, This evaluation involved over 30 peer-reviewed publications and showing really a positive impacts, health benefits of insight, and then no adverse impact on community drug use patterns or public disorder. And then this series of work has really made a major role in Supreme Court of Canada decision for keeping insight open in 2011. So fast forward to 2016, and as many of us know, the public health emergency was declared due to the toxic drug crisis. And then even before the declaration was made, again, like a community has quickly responded to this crisis, and then they started to operate these unsanctioned overdose prevention sites, because it was, even though the insight remained open, but then it was really difficult to open up a new supervised injection site because of the legal barriers. So that in December, those overdose prevention sites were sanctioned. So what we did, this is the work that by our co-investigator, Dr. Marie-Claire Kennedy, is to look at the impacts of scaling up this overdose prevention sites. And then we found that after those sites were sanctioned in December 2016, there was an immediate and sustained increase in people's accessing supervised injection overdose prevention sites, and also all those positive health benefits. So really showing the impacts of this new harm reduction development in our study setting. During the overdose crisis, we also did a series of analysis trying to characterize evolving patterns of fentanyl exposure. And we have shown how socially marginalized, more marginalized populations are really at a higher risk of fentanyl exposure and overdose risk. The opioid agonist therapy is known as a gold standard treatment of opioid use disorder for a long time. But it was in 2016 that the BCCSU has released the first ever clinical guidelines about this treatment in BC. During this clinical guideline development, VIDUS has contributed some local scientific evidence around this treatment. For example, showing the methadone maintenance therapy associated with lower mortality using the data from 1996 to 2011. So even though the OAT is known as the gold standard, that doesn't mean that it's perfect, especially in the fentanyl era. So this recent work led by addiction medicine research fellow, Dr. Lindsay Mackey, really looked at people's dissatisfaction with OAT. And we found a substantial portion of the people on the OAT were dissatisfied with OAT. In the case of methadone, it's 1/3 dissatisfied with methadone. And those people were more likely to discontinue OAT or exposed to fentanyl. Again, this work has really shown that there's so many to improve and optimize this OAT. And then in 2020, we were hit by the COVID-19 pandemic. Dean and I have recently talked about how hard it has been that the people who use drugs have been hard hit by this pandemic. And it's really important to characterize this hardship whenever we analyze and interpret the research data during this period. For example, in data, we have shown that almost one out of 5 people experienced more hunger levels since COVID started. And then this food insecurity were more prevalent among women and the people with mobility challenges. And then also more than 1/3 experienced poorer quality of the drugs they use, and then those people are more likely to overdose. And then for people on OAT, they're experiencing difficulty continue communicating with their prescribers during COVID, so that 1 out of 5 experiencing difficulty or inability to contact prescribers, and those people are more likely to have comorbidity issues and being unable to follow COVID-19 regulations. Those are really important things to keep in mind whenever we contextualize any new initiatives and services introduced in this time period, including risk mitigation prescribing and later on the prescribed safer supply initiatives in BC. So in terms of the risk mitigation prescribing, our recent work has shown that a few months later, after this risk mitigation prescribing guidelines were introduced, only half of the participants in VIDUS Access and Arise were heard of this new initiative. So that if you are not aware of this new initiative, there's no way they can access this new service. And then we looked at this data in more recent data in 2021 to 2022. This awareness of prescribed safer supply has increased to 60%. It's not high enough, but it's increased compared to the past, like 2 years ago. But almost like 2/3 of VIDUS participants didn't even try to access prescribed safer supply in the last 6 months. So that it really shows that there's so many barriers to accessing this new initiative. Among those who were able to access, especially around opioids, then hydromorphone tablets were the most commonly accessed prescriptions, so that 78% were accessing hydromorphone tablets. And then recent qualitative research work has shown some mixed effect or mixed impacts of this new initiative, showing that some people feel positive impacts of this new safer supply initiative, and other people are not. And so we have some work in progress right now to really look at the impacts of this new prescribed safer supply of opioids in VIDUS, including the impact on their overdose risk, as well as some diversion that may be happening associated with this initiative. So stay tuned. So I showed that the hydromorphone was the most commonly accessed prescription for safer supply, but because of the mixed emerging results of the mixed impacts, I was having a conversation with Guy Felista, who is the peer clinical advisor at the BCCSU, and we are like, oh, maybe we should be asking people who use opioids what kind of a pharmaceutical or medical grade opioids they want to be prescribed to reduce their unregulated opioid use. So from that conversation, we developed this question and added to the VIDUS questionnaire, and then now data is here to be analyzed, and we are doing this analysis right now. So this is a sneak preview, and so among people who use opioids, about 2/3 responded that there is some medical grade opioids they want, and then that would make them reduce using unregulated opioids. And then when we ask them what kind of medical opioids do you want, then almost half, 40%, responded that that's a medical grade heroin, that is the morphine, followed by fentanyl patches and the fentanyl powder. And the hydromorphone tablets ranked only 4th, 6%. So you see there's quite a mismatch between what people are prescribed and what people actually want. Of course, the preference of pharmaceutical opioid may change over time as we prescribe more different pharmaceutical opioids, but I'm just showing that there's quite a mismatch between what is available and what people want. And then, of course, in January 2023, like 2 months ago, the BC has started with the 3-year pilot decriminalization policy. So as I have shown, VIDUS has a strong history of looking at the impacts of, a broader, like a social policy like of this kind among people who use drugs. So that we have been working with VANDU and Pivot over the past year, and we are in the planning to do a community-based evaluation of this decriminalization policy using the VIDUS, as well as some qualitative research methods. So it's going to be a mixed methods study. And then we have submitted grants so that hopefully if it's funded, then we want to get started with this new project soon. So in summary, I'd like to emphasize that VIDUS is a really globally unique rigorous research infrastructure. And I think I have shown a lot of examples of really successful research partnerships with local communities of people who use drugs and service providers and policy makers, and emphasis on large translation. So VIDUS has made a lot of landmark contributions to inform policy and program innovations to reduce drug-related harm, so that history of VIDUS is really synchronized with the history of harm reduction development in DC and beyond. And then also lastly, I have shown some of the work in progress and the future research plans. So especially around safer supply initiatives and evaluating decriminalization policy. But those are just two major ones, but there's quite a bit of more, but those are maybe the two major ones over the next few years. I'd like to finish my talk by acknowledging all the study participants, as well as current and past researchers and frontline research staff, administrative staff, and then also our funders who enabled us to maintain this longitudinal cohort study for over 27 years, and then hopefully more in host institutions. And then also, I like to make a special thanks to all the PIs of VIDUS to date, including Dr. Thomas Kerr, who is providing an ongoing mentorship, and then also many of the slides included in the presentation I made today. So thank you very much.
Thank you so much for that, Kanna. That was fantastic. Very, very nice to see the progression of VIDUS over time and such an impressive body of work. We'll move forward now to Dean, if you'd like to take the mic.
Can everybody hear me? I'm good. Really, that was quite impressive, Kanna. It really brought back a lot of memories, especially that picture of Christy Zonneveld. I actually was part of the team that hired her to be the office manager at VANDU back in 2001 or two. So it was really cool to see that. And, I was first involved in VIDUS as a participant in 2000, but I also got involved as a president of VANDU when we were, like the alley patrol that was shown there. I helped start that, get that going. And many of the other wars, the Western Aboriginal Harm Reduction, I wrote their first budget. I was quite influential back then as far as the drug user research went. And so we would work with Dr. Thomas Kerr and Dr. Evan Wood on the questions that were used. And I was always really impressed with VIDUS because we could offer questions that we wanted answers as drug users, and they would find their way into the research. And that really impressed us because in many cases, a lot of the research was somebody would come down to the downtown east side, they'd get their PhD and they'd be gone. And we always came up with that we wanted research that left our community in the same or better situation, and that we always wanted to learn from our thing. I actually started a thing at the Drug User Research Center, or the Drug User Resource Center, where people from VIDUS, and that would come and present their research to just drug users. And we used to call it Harm Reduction 101. It was one of the 6 parts of it. And it was one of the main parts that was listened to, because people wanted to know about that. Power is information is power to us just as much as to anybody else. Anyways, I always liked that about the VIDUS, because I called it action-oriented research, where we could be part of the research. We could look at how that research affected what was affecting our community, and then try to do things that would help our community based on that research. One of the things I was part of the crew that sued the government over Insight, me and Shelley. And if it wasn't for all, I met with one of the judges afterwards, and he said he didn't care about any of that European research. He says it was made in Canada research and mine and Shelley's affidavit that convinced him to rule in our favor. And so I realized then how important research really was if I was going to be good for what I wanted to do, which was not only change policy, but change the laws. And that's always been my thing. I originally got into this because of HIV. All my friends were dying in the 90s. Overdose was still bad then, but it was nothing new. I buried my first friend in 1969 from an opiate overdose. So overdose resulting in death is nothing new to me. But the numbers back then were only 2 a day. Now we have 6.5 a day. So we've really failed in that department. But getting on as far as some of the things that I really like what we've been doing lately, and the work I've been doing with Dr. Kanna Hayashi, is like this risk mitigation prescribing and the safer supply. When they were formulating the questions around that, it was sent to me, and I went through it, and I thought there was a little bit missing about what about doctors who don't participate, and we built a couple of questions around that, and it's become a part of the study now, and it's really informed us of how we need to get more doctors involved into these programs. We also realized that we weren't doing a very good thing of getting to our own people and saying this is available. But there was also the fact that the medical wasn't getting to their doctors. So we found 2 sort of lapses. And that is really, really important to understand those so quickly and to be able to act on them really quickly. And that's what the BCCSU has been doing. We're not only a research thing, we do a training. We do a lot of the training for the medical doctors around addiction medicine and that. So these are the things that, I've just been, I'm actually straight nowadays for the first time in my life, but, through my whole journey of this whole thing about trying to change the way we have to live and how we can have the medical fraternity help us, VIDUS has been instrumental. It really has been. And it's shown us that we can participate, that we can use the knowledge that's gained from that research and apply it so that we can keep, continually helping ourselves. And as I say, knowledge is power. It doesn't matter whether you're the head of General Motors or you're some street and trench junkie. The more you know, the better off you are. And that's what VIDUS has helped us do. And I just want to say thank you to all those. I knew every one of them from the very beginning, even though it was 4 years in before I got involved, but back from Stephanie all the way through Tommy, through Evan, through Kanna, I've worked with all of them, and I'm going to say thank you. You've helped, save my community. We still got a long, long way to go, but we're trying. Thank you.
Thank you so much for that, Dean. That's fantastic. We are now ready to open up for the question and answer period. So if anyone has any questions that they'd like to start off with, please feel free to either use your raised hand function or type out your question in the chat box. So we've got our first question through the chat here. Aisha saying, thank you very much for the presentation. I'm very curious to know how non-fatal toxic drug poisoning is determined. Also curious to know what other data, if any, you may have access to. For example, are you working with the hotel study to determine the number of participants in VIDUS who may be living with acquired brain injury?
Thank you very much for the great question. So our question about the non-fatal overdose has been the same over the past, like over 20 years, and it's a self-reported. So it's a question included in a questionnaire. And we ask people like, in the last 6 months, have you overdosed by accident? It's meaning that where you had a negative reaction from using too much drugs or have had a bad trip. So that's the sort of like a definition we've been using for over 20 years. And because of the longitudinal nature, we can't really change this definition, but that's the way the non-fatal overdose is captured in our data. I think the other question was whether we are linked with other studies, including hotel study. For now, we are not linked with or worked with that specific study, the hotel study. But in terms of the acquired brain injury, we are actually in the process of doing a new neurocognitive assessment in our cohort. It's actually part of the grant aims, the current grant aims with the NIDA, so that's something, new types of the data we're going to be generating in the next few years. Yeah, well, in terms of other studies, we usually work with a lot of other like a disciplinary like a research methods, so that the most maybe important example is working with the qualitative researchers and ethnographers working in the same setting, so that they generate some really hypothesis generating research findings, and then we're going to be reflecting those findings from the qualitative research into a VIDUS questionnaire, so that we can quantify and examine that concept or new emerging findings through the qualitative research with the quantitative research. And then on the other hand, qualitative researchers are also accessing our data to recruit some certain participants for their interview, qualitative research interviews with who have certain characteristics. So that way, like the reciprocal research collaboration has been ongoing over the past, let's say, like 15 years or so.
Thank you, Kanna. I've got 2 raised hands and 1 question in the chat box. So we'll start with the raised hands. Cindy, I think I've asked you to unmute, so you should be able to now.
Hi, yes, it's Cindy. I'm calling in from Treaty 6 territory, actually, in Edmonton. That was great. Thank you so much for that presentation. Quick question, in regards to the prescribed preferred opioid, I was surprised to see that patches was higher than powder for fentanyl. Is that because with the powder, if you're prescribed for safe supply, the person would need to come in to a clinic daily to get their medication, and patches, it's a few days when they switch it? Would that be the reason why you think patches is higher preferred than the powder?
Yeah, that's a great question. And the short answer is that we didn't really ask the reasons for why they prefer patches over powder in our questionnaire. And then it's a hypothetical question, right? If it were available to you, which pharmaceutical opioid would you prefer? So that, it depends on, it's kind of open to interpretation to the participants around whether that specific details of the prescription will matter or not. But by default, the question was a hypothetical, so that those details about the prescription restrictions should not matter to responding to their preference. But yeah, Dean seems to want to add something.
One thing about it too is that people that I'm aware of, the powdered fentanyl, it took too long to titrate up to the amount that you really need. And with patches, they seem to be more liberal with the patches. You know, a person could go from 1 to 8 patches on their backside in a couple of days, whereas you'd never reach the amount that you really needed. Look at Dr. Sullivan's program right now is selling 29,000 mics for one shot. We were talking about 800 mics back then, you know, and how long would it take to get up? So everybody jumped on the patches because at least they wouldn't be sick during that time. And then some of them fell in love with it, to tell you honestly, because they didn't have to abuse their bodies with needles anymore and all that stuff. They could just go in and they could always be on that same thing. So that's a street version of why that might be that way.
Yeah, it just reminds me of the importance of really engaging with various stakeholders in this analysis, and we are actually doing it from a prescriber perspective, and then also from people with a little bit of experience, like people who are using opioids, and really, interpreting the data from various perspectives. So because the VIDUS or quantitative data itself is kind of limited that way by nature, but it's really important to really contextualize these research findings from by collaborating with other players.
Yep, absolutely. Rox, I think you should be able to speak now.
Muted.
Hi. Oh, there we go. Hi. Thank you very much for the presentation. It was wonderful to hear. I had a question regarding participant fatigue. It does, every 6 months for the questionnaire does seem quite often, as I currently, as someone in Vancouver who currently works in clinical trials and recruitment, I've been seeing participant fatigue quite a lot for trials that require individuals to come in quite a bit to answer questionnaires, even at not working in the realm of substance abuse, but wanting to enter the realm. But in the field that I am in, even after asking the sites to answer all these questions, we do see fatigue quite often, and that does affect sort of our study details, our recruitment as well, and just the longevity of the study. I was wondering if there are any methods you're doing to help counteract that.
Yeah, I don't know, Dean, do you want to respond first from?
VIDUS, I've been going to VIDUS twice a year for 20 years. Why did I go that time? Well, one is I got interested in it. And not only that, they've done a very good job of getting back to the people that are participants, what the study's actually saying. As I say, they were very good about coming to my harm reduction 101 and explaining it, and there'd be 60 people in that room and they'd all ask questions. They drive those, it was really, really good. But another one is they kept up with the money. Look, at our time is just as good. And if I'm going to miss a meal, standing in line for a meal or something, because I'm going to go do this thing, then I want to get it paid appropriately. And they always were 30. Now they're up to 50 an hour, which is, about reasonable, I guess. I don't know. I thought it's pretty good pay, actually. And so they've kept up that way also. But two things. One is they've kept up the financial end. And two, they've made sure that the knowledge is translated back to the community in an appropriate time space. We don't want to hear about something pre-COVID now, but we're already hearing about stuff that happened after COVID out of VIDUS. So that's pretty cool.
Maybe I'll just add to, I think the other thing we've learned through some of our related qualitative work is that many people actually relied, especially early on in the study, they relied on the study as a means of having regular HIV and hepatitis C testing. So, when we did qualitative work around access to HIV testing, people would say, oh, well, I go to VIDUS every 6 months to make sure I'm still good. And then the other thing, I just want to give a shout out to Steve Kane and all our nursing staff who really go beyond just simply, collecting samples and administering a questionnaire, but provide people with a lot of linkages to care and a lot of support. I've been in the office in the past when people have come in with stab wounds, et cetera, and said, they're told they want to go, you need to go to hospital. And I know I don't want to go to the hospital. Can you just deal with me here? So I think, going beyond just the research activity is also something that's really helped create that bond with participants and has people coming back.
Perfect. Actually, I had a follow-up question, if that's okay.
Of course.
It was regarding sort of, as you said, the follow-up with the knowledge transfer. What sort of like techniques and sharings and findings have you had that helps impact the research with the community and with the participants, and like those knowledge translation techniques for what has been found? Like how can you talk about that, like the communication?
The best part for us is that, we found out how few doctors were actually taking advantage of the safer supply and the risk mitigation prescribing. But we also found out that we weren't doing a very good job at letting our own people know that this stuff was available. And so we found, as I say, we found 2 lapses, and this is just in the last couple of years. Like when we were formulating those questions, and I said, look, we need more questions about what happens if the doctor said no, if you live in a community that's far away from Vancouver where you don't have access. All this stuff was brought out in that, and we learned. And so, I got on the bandwagon right away and started trying to let every drug user group know in this whole province, which there are a number of, how do we get our membership aware of the fact that they have the right to go into a doctor's office and say, look, this is available, this is called, maybe you should avail yourself of the information so that you can prescribe to it. We've had some not so pleasant happenings, but we've also had a number of pleasant happenings. And I think that's due to the fact that we found out so quickly by asking these questions at VIDUS that this was happening. And as I say, that's why I say kudos to Kanna. I've worked with Kanna now for about 5 or 6 years, like closely, and she lets me in on when they're formulating any new questions. That's fantastic. I was a street entrenched heroin addict. Like I'm going to be able to tell how that affects us, and that's prior to it even hitting there. So that's one thing I'm really happy about.
Yeah. I also like, maybe just to add that, like engaging those like stakeholders in the analysis is also designing the data collection, like just Dean said, it's also one way. Like there's so many ways to really do the effective knowledge translation. It's not just one technique. And then also a lot of, in addition to people who use drugs being involved in research, we also closely work with the addiction medicine physicians and clinicians who are actually involved in writing up and updating the clinical guidelines. So that way, like we can also inform the service provision around substance use treatment. And then also, a little bit more technique might be the plain language research summaries and policy briefs that's been really pioneered by Thomas and Evan for the 10 years ago, and we've been still doing. And those are also very important. And yeah.
And as Dean mentioned during his remarks earlier, pre-COVID era, we did have a standing policy of, if trainees wanted to do research using VIDUS data, they also had to agree to go and do a presentation to members of the participant community on the topic of the research that they were undertaking.
Yeah, definitely sounds very multi-pronged, a very, very multi-pronged approach. We do have one last question. I realize we're at 1 o'clock, so if people need to leave, please feel free. But before I get to that question, I do want to let everyone know that we will be posting the video for today's presentation on the BCCSU website, along with a list of key peer-reviewed published articles that go alongside Kanna's presentation and an infographic visualizing today's presentation. So the last question I have here is from Hudson, and it's for Kanna and Dean. Do you think the limit of 2.5 grams in the decriminalization policy will limit the effectiveness of the policy? And is this something that will be evaluated?
Well, I'll leave the evaluation up to Kanna, but I think the numbers are relevant, to tell you honestly. 2.5, 3.5. I think the main thing that's going to stop is from people who are entrenched having to go through the circle of law enforcement and then through the criminal justice system. That's going to stop. The main thing is people would get charged with a small amount of possession of way under 2.5 grams, but they would miss their court date. So then they would go through a whole thing through the courts but now they have a serious charge. Failure to appear is a lot more. They would drop the drug charges, but they would get convicted on that. So the predicating charge of the drugs was, got them into trouble. And this is going to stop. That kind of nonsense is going to stop. It's not going to affect the overdose rate by any chance. And 2.5 grams, I'll tell you, you think about 2.5 grams of cocaine, that's almost a half ball. Like most people don't carry that much around on them, even if they're going to go out use personally. Most people have more than that are dope dealers. So I can really give a shit. Anyways, go ahead, Kanna.
Yeah, it's actually, we already added the question about the 2.5 grams threshold thing into the VIDUS questionnaire. So we will see what kind of data we're going to be getting. And then, yeah, we're going to be analyzing that in the next year or two. Yeah. Oh, Amanda, you're muted.
Thank you.
Yeah.
Thank you very much, Kanna and Dean, for your presentations today and for sharing your insights with us. We appreciate it. And thank you very much, everyone, for joining today and taking time out of your day to meet with us.
Thanks to all you researchers, to all of you out there. Thank you.
Thank you very much.